Uh, Take care. So, am I audible?
Yes.
Yes.
Yes. So, good evening, everyone. Everyone, it's a pleasure to welcome you all to today's insightful session on iStent. We have with us Dr. Prakhyat Roop as speaker today. Dr. Prakhyat Roop is a globally acclaimed ophthalmologist and refractive surgery pioneer, renowned for his groundbreaking work in spectacle independence technologies. He was trained at AIMS New Delhi at RP Center of Ophthalmic Sciences, and he has been awarded the Best of the Best at ASCRS Film Festival in 2024 for invention of negative dysphotopsia ring. He is a two times winner at Winning Pitch Challenge at ASCRS 2019 and 20 consecutive years for innovation of intraocular lenses, lens design, and laser based vision correction. He holds two patents, two in US, two patents in US and four in India. And as founder of Acura Vision Clinics, Roop Netralaya in Meerut, he leads India's first R&D partnership with Zemer Ophthalmology for clear lenticule-based for the clear lenticule-based refractive surgery platform, offering flapless AI-driven precision for patients. His expertise spans LASIK, SMILE, cataract surgery, presbyopia solutions with patient-centric philosophy, and that has transformed eye care standards in Delhi, NCR, and beyond. As panelists, we have Dr. Pratyush Ranjan and Dr. Neha Chaturvedi. Dr. Pratyush Ranjan is distinguished ophthalmologist renowned for his surgical expertise and innovative contributions to the field. Trained at premier institutions with extensive experience, he has developed novel techniques like RMSICS and cartwheel chop, earning international recognition. He has authored many publications and often serves as speaker and trainer in various national and international conferences. Currently serving as medical director at ASG Hospital, Dr. Ranjan is also committed to promoting eye health through his NGO, the Ashoka Foundation. Dr. Neha Chaturvedi has been alumni from AIMS New Delhi, and she has been a gold medalist and top ranker. Her expertise, like surgical perfection, dedicated patient work and research towards improving all areas of patient care. She has served as surgeon since 2012, first in Premier AIMS and named AIMS New Delhi, then in AIMS Bhopal, and now she's a consultant in AIMS Bhopal since 2017. Over to you, Dr. Prakhyat.
Thank you, Dr. Darshana. I think we'll start now. We have around 18 people already joined. So let me just share my screen. Can you see my screen now?
Yes.
Yes.
Okay. So let's discuss about iStent inject, which is basically a trabecular meshwork bypass. And we are going to focus this presentation on the practical aspects of where it figures in our practice. So we are going to discuss about who is a good candidate for this procedure, when should we be performing it, and why should we be including it in our practice. So if you look at the treatment options right now for glaucoma management, then we have medications and laser-based procedures, which are like SLTs or sub-threshold, whatever lasers that we have. Medications have the problem of adherence, and the other thing is that medications can only be used in relatively fairly milder cases where we get good IOP control with one or two drug combinations. When it comes to having a stricter IOP control, we look for options which are surgical. When we look at surgery, we have the conventional filtering surgery, which is a trabeculotomy or the trabeculectomies in pediatric cases and in adults, trabeculectomy being the mainstay. And for the refractory cases, we reserve the AGVs and other procedures like the ADI valve or things like that, tubes and shunts. Now, the thing is that when we talk about this dilemma or this dichotomy between medical and surgical management of glaucoma, In medical management, we face the challenge of compliance. Number one, compliance can be affected by multiple reasons. One being the cost, second being the side effects, and third just the change in lifestyle that happens where you have to remember to put the particular drops at the right time. The other problem with medical management is a diurnal variation that is inherent to the use of drugs, because the drug onset of action and its peak action and the fall in the action or the concentration of the drug happens throughout the day, and that causes a continued diurnal variation even when we are putting proper medications. That leads to us setting a lower target of IOP for patients who are going to stay on drugs long term, because we don't want them losing visual field in spite of being compliant to the drugs. And overall, if we look at drugs, they are costly enough. So if we look at the standard drugs that we use, then on an average, a patient would have to put at least 1500 to 2000 rupees per month on his drug costs for glaucoma management. If we look at surgical management, then it does have the advantage of minimal diurnal variation, which is an important aspect when we look at those patients who are deteriorating in spite of showing us a controlled IOP. It does have a one-time cost, but the main deterrent for surgical management of glaucoma is the surgical risk, which is both perioperative as well as long-term. So let's look at the medical management and its challenges. This is a paper published by Shroff Charity Group, where we can see that fully compliant patients are just 50%. So that means that if we are putting a patient on medication and that is our long-term strategy, then it is very likely that somewhere down the line we are going to have to shift from that strategy. And diurnal variation, it has been shown to affect visual fields and cause their deterioration more rapidly. So this is a study where it shows that patients who had lesser diurnal variation, that is the diurnal variation with range of less than 7.7 millimeters, had a more stable visual field as compared to patients who had a higher diurnal variation. If we look at surgical options, currently we reserve surgical options for the more severe and refractory cases only because the risk associated with trabs and shunt devices outweighs the benefit of the surgical option when it is considered for a mild or moderate glaucoma, because we don't expect them to rapidly deteriorate even on medications. So it's more like saying that we are going to delay the loss of nerve cells and make it much slower, make it much protracted course, because we are not going to take the risk today. And that is a valid risk benefit analysis. When we talk about iStent, it actually figures in the mild and moderate it actually figures in the mild and moderate category of glaucoma only. So we are not actually targeting the severe or the refractory glaucoma cases when we are talking about the mix. The risk associated with conventional surgery is completely addressed in these mixed procedures, and that is why they become an option. Like surgical options become open for mild and moderate cases as well. So basically, micro-invasive surgery or trabecular meshwork micro bypass figures somewhere in the between of these two different approaches, and it is like a bridging, so to say, the bridge therapy between the two procedures, not by saying that we are going to buy time for the patient to deteriorate to a condition where he needs a trap, but we are saying that it is an interventional procedure that does not have the risks, although it may not be that efficacious also as a trabeculectomy or a shunt procedure. So let's first look at what iStent inject W design is like. So this has basically a central outlet which is in the center. Right in the center, there is a hollow. So that is 80 microns in diameter. Then we have side flow outlets, which are four in number, which are basically in this shoulder region, which is shaped like this, shaped like an arrow, because it basically pierces through the trabecular meshwork and lies in the Schlemm's canal, basically. And 15 microns holes are there on all four sides. So we'll discuss why that is the case. And there is a rear flange, which is basically retained in the anterior chamber, and it kind of stops the stent from going further deep into the trabecular meshwork. And the central inlet, of course, like I said, there is a hollow 80 micron pore lumen through which aqueous can pass like this. And these 50 micron holes from where aqueous can pass this way. So basically, aqueous can come out from all these four outlets. And this thorax region is where the trabecular meshwork engages on this uh, stent and keeps it in place. So basically, when we have implanted the stent, this portion is visible to us, and this portion is in the Schlemm's canal, and the neck portion or the thorax region is where the trabecular meshwork engages with the stent. Uh, so basically, this design is slightly different from your earlier design, and the difference lies basically in the rear flange, which has been made little broader so that complications or it becomes easier to implant it. Right now, we are using this, so we are not going to discuss the previous versions. So the surgical procedure is very simple. You have this trocar, which is on which this stent is mounted already. So you have to inject it, dimple it, press the activator, which basically is a button that you have to press once you are in the right position, and the stent goes in. Now, the way it works is that it basically enhances the conventional outflow. So, if the blockage of the outflow channel or the cause of glaucoma lies at the level of the trabecular meshwork, then this stent is going to work. If the trabecular meshwork is not functioning properly, it is causing more resistance to the flow of aqueous, which is why the IOP is rising. Then the stent bypasses the trabecular meshwork and the aqueous actually flows into the aqueous veins of Asher, which is seen here. If you see, you can actually notice enhanced outflow in these channels, the aqueous veins of Asher, with the stents implanted in the nasal quadrant. So this is a study that was done by ASOCT scans taken at different places. It shows that at the temporal side, you can see this collapsed Schlemm's canal. There are two stents implanted here, and the stents are actually seen as these shiny uh, dots here. And just adjacent to these stents, the Schlemm's canal actually shows a bigger lumen. That is, it has become open. So that shows that the conventional pathway of aqueous outflow actually becomes activated by this stent implantation. The surgical technique is very simple. So, when we are talking about this procedure, we are primarily targeting mild to moderate glaucoma, those patients who would conventionally not undergo a trap. So, both glaucoma surgeons and cataract surgeons are the right candidates to be starting this procedure. Surgical technique, the most important thing is actually visualizing the angle. So, we have to practice that. Most of us are trained to do gonioscopy, so it becomes easier to identify the angle structures. But this is how the setup has to be. So we ask the patient to uh, turn their head around 25 degrees to the opposite side, and we tilt the ocular of the microscope by about 30 to 35 degrees. So 25 degrees and 35 degrees, that becomes around 55 degrees That is the angulation that we need to have. We have to aim for a direct gonioscopic visualization and avoid a parallax. Basically, we want an on-fast view of the angle. So that's what we are aiming for. Now, let's have a look at the surgical technique. So the cataract surgery, I'm going to skip. So cataract surgery happens, most of the procedures that I do are combined, but we can also have them in a phakic patient, and we can also have a pseudophakic patient who undergoes only iStent procedure. But what I am going to show is most of them are the combined procedures so that we have an idea of how the procedure happens. So this is an eye prism. It's a self-retaining prism. Once you just put it on the cornea, it has few spokes, kind of like spikes in the football shoes that we have. So they basically engage with the conjunctiva, and you don't have to really hold it. You can just support it or even sometimes leave it, and it stays in place. It's a good device to actually begin doing these procedures. You visualize the angle, retract the plunger, and then you just engage your trocar in the trabecular meshwork, which is basically seen sometimes because of the reflux of blood into the Schlemm's canal. So you see the pink line, that is a pigmented trabecular meshwork that is overlying the Schlemm's canal. So you implant in the aiming for the anterior trabecular meshwork, because if you aim for the anterior trabecular meshwork, your trocar actually pinches or pierces in the middle or the posterior pigmented trabecular meshwork. So this is one stent gone in, and you can see the reflux of blood coming into the AC from the central port. And we go to the second one. Now, sometimes you can have a lot of blood, so you may have to clear it. But here I have a clear view, so I directly go ahead and inject the second implant. And the reflux of heme back into the AC actually tells me that I have made a continuous channel from the AC up to the Schlemm's canal. And this is the end of the procedure. Moving on, I'll show another case, a simpler case where I just go ahead without any heme. You will be able to visualize it better. So the routine cataract surgery happens. You implant the IOL, you put pilocarpine, and then you place your prism. And as soon as we place our prism, we can actually see a very nice view in this eye, because he's a myope. So we can actually see the angle structure pretty clearly. The media is very clear. So I just did this surgery 2 days back. I thought I'll share this. So this is completely not sped up. This is real time. So you go in with the so there is a sleeve. The protective sleeve comes on the stent, and there's a button to retract the protective sleeve. So we keep the sleeve on, and then we enter from the main port. We filled the AC with high density, high cohesive viscoelastic, so Helon or Helon GV. And after that, once we are in the AC, then we
How are
retract
you?
protective sleeve.
Chicken a bit.
So once we've retracted the sleeve, we need to visualize the trocar. We change the fine focus to visualize the trocar. Once the trocar will be clear, only then will I proceed on injecting it. So now that the trocar has become clear, I go closer to the trabecular meshwork. Here you can see that there is not enough pigmentation, but the reflux of blood shows that pink line, which is basically our target. So I have to take my trocar, which is right in the center of this hollow tube, and that has to go in. And once I engage there, I inject my stent and come out. So when we start implanting this, the process exactly is goes like this. So you engage, press the button to activate the hammer that actually pushes the stent into the trabecular meshwork. Wait for 2 seconds with that button pressed, and then you come back and then you release the button. Those 2 seconds is basically what the company people say that is required for the trabecular meshwork to actually occupy the space at the thorax region of the stent, so that it doesn't come back with your uh, trocar itself. So one is done, and I directly proceed on to the second. Dimple it slightly, inject, and come back, and that is the end of the procedure. So it takes additional 2 minutes apart from the cataract surgery to actually perform it once you get into the practice. And just to confirm the backflush of the blood from the Schlem's canal, I am actually doing an IA with the prism in place, so that when the IOP reduces and I remove the cohesive OVD, then I'll be able to probably see the blood coming back into the AC. So the AC becomes shallow, and then I see that blood is actually coming back from both the stents. So you can see that it is coming back from both the stents when I shallow the AC. So once this is done, we go back to the normal orientation, bring the patient's neck back, keep our microscope perpendicular, get the good red reflex, and notice one more thing here. Notice the blanching of vessels that happens along the nasal and inferior limbus here. So when I just go back to the normal view, have a look at the nasal part of the limbus and the inferonasal part of the limbus, and then you will suddenly see this blanching. So you see this happening right now. So that means that there is fluid that is flowing into the aqueous veins, which is connected to the episcleral vessels. So you see that when I build the pressure, you will see blanching here. So all this area, the small vessels have completely blanched. And when I release the pressure, you will see the vessels are becoming redder. So have a look at this vessel. This is the inferior part, and the aqueous will actually flow here. So this vessel completely disappears. So this confirms to me that I have established a continuous channel between the AC and the episcleral vessels. So this is a very reassuring sign that this stent is going to work. Sometimes we can have challenges. It's not like it's always a 2 minute procedure. So like in this case here, because of the pigmentation being lesser or lesser than what we are used to seeing, you can have a problem in identifying the angle. It's a myopic patient, the iris processes are here, so it can be really confusing as to what exactly is the angle. Sometimes the angle structure may, you may feel that the Schwalbe's line is actually the trabecular meshwork, or sometimes the ciliary body band may feel to be the trabecular meshwork. So here, what may appear to be the Schwalbe's line is where I am implanting the stents actually, but it's really the trabecular meshwork. So the reason I know that this is the trabecular meshwork is because I did a preoperative gonioscopy for this patient. So I know the structure of the angle, and that is why I'm confident when I'm going into the surgery. I already know what I am looking for. And once I visualize that, I'm confident that this exactly is genuinely the trabecular meshwork. Another problem that commonly happens while implanting this stent is a trocar bias, which is basically saying that once you push your uh, trocar in, there's a fine needle that has gone into the trabecular meshwork. And then, because of the jerkiness or the instability of your hand, or because you are a little bit kind of anxious because you are implanting a very expensive stent, you may have a lateral movement. What that lateral movement causes is that if this is the barrel or the outer shell, the outer diameter of the stent, and this is the trocar, then your stent is lying somewhere here. And when you move laterally, this central trocar is actually turning this way. So when you push your stent, it actually doesn't thread through because you have a constriction here and the stent is going to come and stop here itself. So this is what is called the trocar bias, and this is something that has to be taken care when you are implanting, when you're pressing the plunger. So I had a trocar bias just half a second before I actually pushed in the stent. Sometimes it can happen that you inject and it doesn't stay there. So here we see that I go ahead and push my stent first. This is the first stent. There are two stents in every uh, assembly. So you have to put both stents for it to work optimally. Now here the thing is that I feel that I have implanted it more posterior than it should be. So you can clearly see this pink line, and my stent is actually posterior to it, closer to the iris root and not exactly in the trabecular meshwork. But because I have another stent already, which is loaded in the iStent itself, so that is why I want to first take care of that second stent and then I'll revisit the first stent again. So I go ahead and now I correct my position and put the second stent. And as soon as I put the second stent, you see that it comes out. So now I have to rethread this and inject it. Looks a bit scary at that moment, but it's fairly simple. So you just come out and you can, now that I have become used to it, I actually rethreaded it there only. But actually, you can come out, close your trocar, come back, go with an SFIL forceps, hold this stent, take it out, and then rethread it. So I'll show you how to rethread it. Here I have done it in situ only, and I will go ahead, put in some OVD and again inject this stent. But I'll show you how to rethread it later. So I clear my media again. I have a clear view of the Schlem's canal again, and I go ahead and I wait for 2 seconds, and that does the trick. And now I check by gently nudging the stent. I am checking that it is in place and it's not loose. Then I go ahead and take out the first stent, and now I'll show you how to thread it outside. So you put this, it's very, very microscopic. If you lose its visualization under the microscope, sometimes you may lose the stent itself. So always be very careful to have the right hold. Have some sterile sheet, or here I have an IOL cartridge where I have injected some HPMC and placed the stent there. It's a heavy titanium, dense thing, but very small. So if you put it on OVD, it doesn't go anywhere and it is kind of going to go down and rest. And then you can go back and thread it just as I show here. So once I've threaded it, then I can, with that stroke of HPMC actually, I kind of pushed it further. And once the rethreading is done, you go back and do the injection. Sometimes it may not be possible to inject both the stents in the single go. So you inject one, and if one is well placed, you can actually, there is so much of backflush of blood from the phlegm's canal that you see the whole AC is actually getting filled and the media is too hazy now. So what I did is I go back and I removed all of the OVD because the OVD is also now blood stained. Everything is out. Then I inject OVD again and do the whole exercise again. Trust me, it is much better to do this whole exercise again than to try and inject it in the first go itself. You are going to land up with much more surgical time if you try to do that. So, clear media is very, very important for the success of this procedure. I have done about 21 or 22 procedures till now, and I have analyzed the first 9 or 10 cases for whom I have enough data now. So I have done procedures in patients who were preoperatively on 2 to 4 drugs, on an average 3 drugs, and their IOPs were partly controlled. So they were not achieving their target IOPs, but they were close to their target IOPs. So if you look here, the target IOP is 16. The patient's IOP is 20 on 4 drugs. 18 is the target, 19 is the IOP currently on 4 drugs. And you see the cupping shows a large variation. Sometimes I've even done surgeries on zero point 0.9 cupping also. So cupping is not really the factor that decides whether the patient is a good candidate for iStent or not. What you have to decide is whether this patient's Schlemm's canal has the potential to open up or not. And the way you get to know that is when a patient responds to medications in the expected line of manner, in the expected percentage of IOP reduction, then you can say that an open angle or the indications for basically iStent, in those cases iStent is going to work. If a patient is not responding to medication, suppose a patient comes with a 30 IOP or a 35 IOP, and you put him on two drugs, combination of 3 drugs, and the patient's IOP does not come back to the normal range, then that patient is not a good candidate. Suppose the patient only has a response of 5 or 6 millimeters, then it is likely that the patient has had a chronic glaucoma long term, and that is why his Schlemm's canal has remained collapsed for a long time and has scarred. So in those cases, the stent may not work. So to begin with, the ideal patients would be your open angle glaucomas, pseudo exfoliation, steroid induced glaucomas, pigmentary glaucomas. I have done surgeries in a patient where there was primary angle closure, where my father had done a PI 20 years back, and the patient was following up with him for the past 20 years on medications, well controlled. But when we did her cataract surgery, she wanted to get rid of medications also. And because I was able to visualize the angle properly, I actually did an eye stent and it worked wonderfully well. In fact, this is her 16. Her target pre-op IOPs were 20, and she was on a combination of multiple drugs. So Trisopt and another combination, I think. And she achieved her target IOPs actually post-operatively after 6 months. So if I look at iStent and my practice, my patients have a issue of long-term compliance, number one. Chronic dry eye and meibomian gland dysfunction that exacerbates with long-term use of medications, a slow decline in their RNFL, and which is often missed. And also, I have a lot of younger patients who are detected early for glaucoma. And now I'm thinking that this person is going to live for another 40 years, and I am going to probably be seeing him for another 30 years. And this patient is always going to come back to me every 4 months, every 6 months, either with dry eye or with problems of uncontrolled IOP or some other side effects of medications. So there is only so much that I can do for the long term. And that is where I feel that iStent figures in our practice. Why I preferred this mixed procedure over the others is because iStent has a long-term efficacy data available. There's a 10-year study that has been published from the US data, which clearly shows that if the stent works in the first 6 months, it works for years at stretch. And the reason is very logical. If the Schlem's canal opens and the fluid begins to drain through it, then there is no reason for it to collapse. If the stent doesn't work initially itself, then it is less likely that later it may start working. Sometimes it happens that you have a partial effect. So initially, the first few weeks, you don't see the IOP completely controlled. You have to maintain the patient on one or two drugs. But then slowly you start seeing that the channel continues to open up. So it's like basically there was a collapsed pipe that has slightly opened up, but as more and more fluid goes through it, pushes through it, it kind of keeps on becoming wider and achieves its normal anatomy as the time passes. The physiological outflow basically helps in terms of having a better surface, and overall the structure of the eye, the corneal health, the conjunctiva, everything starts to appear very normal as weeks pass by. There are no safety concerns as compared to a trabeculectomy. So I am not worried that tomorrow the patient is going to come with a flat AC, I'm going to have a bandage. The downtime and morbidity is almost the same as cataract surgery. And my post-op regime is also the same as cataract surgery. In fact, I taper steroids faster because these are glaucoma patients. So that's the end of my presentation. I think we can discuss whatever mm, Neha ma'am or if we have sir, Kaushik sir, whatever you want to discuss.
Hi, Dr. Prakhyat.
Hi sir.
You presented, yeah, very well, and it was a good informing and a good something which we add to our surgical practice and for glaucoma patients. As such, we have a lot of glaucoma patients, and these are the similar challenges which we face every day.
Right.
So it was a good presentation. You explained it very well. We could see the surgical demonstration also. The way it was explained was very well. We'll definitely try to add, and we wish to add to our practice uh, this technique. And I heard about it earlier also about you doing such a good work on this. I would like to have maybe more interaction in this on this topic. So I would like to ask you. Definitely presented some data. How many cases have you done so far?
Sir, I have implanted about 22.
22.
Some of them
And
are
you are
unilateral, मतलब एक आंख हो चुकी है, थोड़ा
okay.
टाइम में दूसरी होगी तो
Got it. And mostly you do along with cataract surgery?
sir, I have not done a phakic patient yet.
Okay.
Either a pseudo phakic who
Okay.
goes only for iStent or
Yeah.
combined.
Okay. That's good.
So basically, जब patient
Mm.
phakic है and if
Mm.
they are crossing the age of 48, 49 years,
Yeah.
then I feel that it adds kind of a burden on them. First, I do a stent. Then
Yeah.
sometime later, 2 or 3 years later, I'm going to ask them for a cataract surgery also.
Yes.
So
So
it
it's
makes it more
yeah.
cost effective for them. At 50
Mm.
years of age, there is not a lot of time that remains for a cataract surgery. So
Yeah.
that's
Yeah.
why I combine it. But a lot of surgeons actually do it
Mm.
in phakic. And in phakic, actually, the benefit is that the AC does not become very deep.
Okay.
So your intuitively your stent goes more parallel to the iris.
Okay.
Here,
Okay.
because you have a lot of depth in the AC, when you will start doing it, you will realize that your tendency is to point downwards because you
Okay.
have a lot of space. So
Yeah. Yeah.
that is something that has an advantage in phakic. The disadvantages is obviously if you don't fill it well with the cohesive OVD, then you may injure the lens.
Okay. Okay. Right. And what kind of expectations we can have for the medical part, medical management part? You what percentage of IOP reduction do you feel we can achieve with this surgery?
So if we look at, like I showed you my data,
Yeah.
we operate it in those kind of patients who are on 3 or 4 drugs.
Yeah.
See, if there is one drug combination, like if the patient is on, say, Ganfort,
Yeah.
then patient is also compliant. There are not many side effects, and
Mm.
uh, एक ही drop डालनी पड़ती है. So
Mm.
we are not that bothered. Even the patient is not that concerned.
Yeah.
When it comes to combination of 4 drugs, the third,
Yes.
fourth drugs efficacy is itself reduced because
Yes.
they are not now going to cause that 25% reduction. They are only going to add 5 or 7 or 10% reduction.
Right.
Side effects are increasing. So
Mhm.
in patients who are at the borderline of control
Yeah.
with these 4 medications or with the five
Right.
medications, those are
Yes.
the patients where I choose for iStent. And in barring just one patient, I have had all the patients drug free till
Yeah.
now.
So I could see your data also, and that was quite good, even better than the control with the medicines with 3 or 4 drugs.
Definitely, sir. Definitely.
The post-op control was rather better than that. And if we can
Actually,
achieve such a situation for such glaucoma
actually, मैं
patients, it's
आपको
a
एक
wonderful.
I
Mm.
will share an anecdote with you. This patient who I'm talking about, primary angle closure patient.
Yeah.
Initially, matlab, the company people also, they don't say that you can do it in a configuration of angle closure.
Okay.
So the reason we did this for her is she's a very close friend, like a family friend of ours, and
Okay.
she's a very well-to-do lady from a
Mm.
very reputed industrialist family. So she wanted the best with everything, and she's been following up with my father for 20 years. She got a PI done even before any goniosinike had
Mm.
formed. Like she's the
Okay.
ideal patient. When
Right.
I did her gonioscopy, her angles were open.
Okay.
So when we decided to do her procedure, she was on 4 drugs and she never had a side effect actually.
Okay.
So she was compliant. She had some dry eye, seasonal variations. So she was a very compliant patient and not very complaining also. But when we
Okay.
said that we may try this and maybe that we get successful, she
Yes.
was not bothered with spending the money. So that
Yeah.
is why we went ahead and did that. Now, when she comes to show us for follow up, the biggest thing that she tells us is that need for lubricating,
Yeah. Yeah.
like sometimes she used to say, मैं अपने पोते पोती को पढ़ाती हूँ तो आंख में
Mm.
पानी आता है, इरिटेशन होती है,
Mm.
कभी खुजली होती है, हमेशा ड्रॉप डालती
Yes.
रहती थी. तो now she does not have any drops at her home, eye drops, any.
Wonderful.
So
तो ये
she is
सबसे
very,
अच्छा
very.
अचीवमेंट है. यस, ये सबसे बढ़िया चीज है. वी कैन get someone free of glaucoma drugs, and for long term they have been using, and other another many years we are expecting them to continue as such. So that compliance is definitely a problem that becomes a burden for a patient. And other than that, the side effects which we have from glaucoma drugs for so long to surface problems. So it's a wonderful thing. So very good insight, and I was quite excited and optimistic to hear on this topic from you. I followed each and every point which you explained,
Thank
and
you,
it was
sir.
a wonderful presentation from you. Definitely, I would wish to visit you, or otherwise I'll invite you to our center to
Sir, you can
demonstrate these
plan
cases.
cases, no
Yes.
problem. I was discussing earlier also
Yeah.
with Raghav sir also that
Yes, I
we
just
can.
wanted to pick in. Hello.
Yes, Raghav.
I'm so sorry. Prakhyat, sorry to interrupt. Actually, sir, Prakhyat was so passionate about this device and his results.
Mm.
He was like, sir, sir, ये ना sir हम कर सकते हैं, sir बहुत अच्छा result है. And to the
Mm.
tune on the same sitting, he told me कि sir जिस भी सेंटर में शुरू करना हो ना, सर आई विल
Mm.
गो माई सेल्फ. आप केस इकट्ठा करके रखो. एक दो केसेस
Oh.
मैं करता हूँ, एक दो केसेस जो भी करना चाहता है उसको मैं कराऊंगा सर. But
Mm.
I'll go myself. पर सर आप शुरू करो.
Yeah.
So I thought, so why not we just start with this lecture, and then I requested Dr. Pratyush and Kaushik that यार एक बार ये रखवा सकते हो तो रखवा दो, because Prakhyath is very passionate about it and he volunteered कि सर मैं खुद आ जाऊंगा करवाने. So I think that is what I think Prakhyat was saying.
So that's what explains about the confidence he has about this procedure and the results he has achieved. That's why the results are also there.
एक्चुअली सर,
And
इनफैक्ट जब हम मिक्स की बात करते हैं ना, तो हम आरपीसी में जब हमें पढ़ाते थे तो कहते थे मिनिमली इन्वेजिव, मिनिमली इफेक्टिव.
Yeah.
तो हमने यही पढ़ा है और एक्चुअली में ऐसा है। मैंने बैंक के रिजल्ट्स देखे, मैंने, क्योंकि सब लोग करते हैं, केडीबी करते हैं, ट्रेबेक्टोम करते हैं, बहुत सारे मिक्स करते हैं ग्लॉकोमा सर्जन्स, एंड all of them are either very less effective or their effect wears off with time। जैसे
Okay.
केडीबी का है, वो 1-2 साल काम करता है, फिर वापस से ड्रग्स पे जाना पड़ता है, बिकॉज वो फिजियोलॉजिकल नहीं होता। आपने ट्रेबेकुलर मेशवर्क निकाला, वो थोड़े टाइम आप फिर धीरे धीरे करके स्कार होके वो क्लोज हो जाता है।
Close with it. Yes.
तो बेसिकली इस डिवाइस की जो मुझे अच्छी बात लगी वो यही थी कि इसमें ऐसी कोई चीज नहीं है जो लॉजिकली वक्त के साथ बंद हो जाएगी।
Hmm.
और डेटा
Yes.
उनके पास है। अब डेटा तो आप भी जानते हो, मैं भी जानता हूँ कि मतलब इतना ट्रस्ट नहीं कर सकते
Yes.
अमेरिकन्स
कितना
का।
लंबा do you expect that this thing will work on?
सर जो द एफडीए डेटा एंड द यूएस पब्लिकेशंस दैट दे हैव आर गोइंग बैक टू 10 years
Without
Okay.
10 years without the like with
without the drop.
some
So
kind of
basically what they have done the Kaplan-Meier analysis and 10
मतलब
years
प्रोजेक्ट
they
किया
have, हाँ प्रोजेक्ट भी किया है, और कुछ मतलब कोहॉर्ट है उनके पास, सिग्निफिकेंट नंबर्स हैं, 100 के ऊपर हैं जो 10 साल हो गए हैं। वो फर्स्ट जनरेशन वाला था, उसको ऐसे करके डालना होता था। पहले हम लोगों का पीजी में आता था क्वेश्चन, उसमें आती थी
Hmm.
वो फोटो उसकी, वो अब नहीं है। तो अब ये इंजेक्ट वाला है तो हमारे लिए आसान हो गया, अदरवाइज तो उसको थ्रेड करना पड़ता था थोड़ा सा
Yes.
ट्रेवल नेटवर्क में। सो वो उसका डेटा भी है उसमें इंक्लूडेड। सो इट शोज दैट द ट्रेंड ऑफ आईओपी डज नॉट शो अ राइज,
Hmm.
and the reason, logical reason for that is this structural change that we can see, that if the Schlem's canal has now opened up and
Yeah.
aqueous which was meant to flow physiologically through it is flowing through it, then what is
Yeah.
the reason that the stent would close? The lumen of the stent has to close for the pathway to close,
Which is not possible.
Right.
which is not going to happen.
जब पोस्ट ऑफ हाई कितने लोगों में होता है? मतलब ये तो इंट्रा हुआ, मतलब पोस्ट ऑफ भी होता है कि क्या है? मतलब व्हाट इज योर एक्सपीरियंस?
Sir,
इमीडिएट पोस्ट ऑफ।
post-op regime mein what we do is, if the patient is on 5 drugs, then I stop the bimetoprost or latanoprost, whatever, मतलब the prostaglandin analog हम रोक देते हैं, बाकी हम
Okay.
कंटिन्यू कर देते हैं।
Hmm.
And 10 days later we stop one drug, then 20 days later we stop another drug, and by that time the steroid is also tapered.
Hmm.
After that we see the IOP response, and if the patient has come down to the target IOP, then we stop all drugs.
Hmm. Good.
So
What
some
about
patients show the IOP spike because they are myopes. So some patients do show that they are not achieving their target IOP in the first 2-3 weeks.
and what about post-op hyphema?
Hyphema doesn't happen.
Do you give any pupillary constrictors to avoid past presentation for any sort of bleeding or?
Only if no, so not for bleeding, but only if I see that there is not enough space. For example, in a phakic patient, you would want to give pylo. Or like I said, this primary angle closure patient, which I did, which is not currently an indication, the official indication for doing an iStent. In those cases, I do give pylo, but otherwise, no. I don't give neither a dilator nor a constrictor. And hyphema, even if it is on table, it doesn't continue. Like it's not like the bang or things like that where you will find a hyphema post-op day one. Never seen it.
And what about the cost?
So
The
right
most
now,
important question has been asked by Dakshna.
all of the patients that I have operated are insurance. So insurance
Okay.
gives full reimbursement because
So
the stent.
otherwise also, what kind of package do we have?
Sir,
Even if we may keep a cash
so
package.
we are right now at our center, we are charging 1.75 lakh.
Okay.
And the cost of the stent itself is 1.56 lakh.
Okay.
So
So,
that is why the insurance actually pays for it.
Hmm. Okay.
So
In
it
insurance,
is,
it's covered. Yeah.
I have
it
a
is
question.
covered and पूरा मिलता है insurance से.
So basically, I mean, in some cases, when we combine cases, I think we have seen that when we combine two procedures together,
Our second surgery, generally insurance companies, they give only, I mean, part payment for the second procedure.
Yes, sir.
So how do you tackle with that?
So we do the primary procedure here is the mixed procedure, which is the iStent inject. The secondary procedure is the cataract procedure, and you will get less for cataract, which is fine.
Okay.
Because if you will see the economics, it works out really handsomely.
Okay.
Okay.
When you see the cost to you for the stent, the cost to you for the IOL, and the total cost for the procedure that you are putting up for the insurance claim, you will find that it is very, very good.
Also,
So as of now,
I'll just like to add that uh, usually, I mean, in all compared to all other mix, we, I mean, be it KDB or Bang or GAT, we actually de-roofing a lot of trabecular meshwork, which is not physiological. That's the reason why iStent is, we have generally post-op IFM is also less, because we are hardly touching 2 points of trabecular meshwork, and compared to other those things, we are almost de-roofing at least half or a quarter or a full trabecular meshwork.
Right, sir. Exactly.
I would like to invite the panelists, Dr. Pratyush Ranjan and Dr. Neha, to also contribute.
Uh, Very well, very nice results, Prakhyat, and very good presentation. And thank you for the encouraging results. We would also like to start this procedure. I wanted to ask, and is do you have any experience with the three stent Infinity?
Ma'am, it's not available in
Not
India.
available? Okay.
It will take around another year and a half probably to get the FDA
So
approval.
the MIGs, all of them are very late to come to India, right? Right.
Expensive, and
Expensive.
probably the thing is that now that uh, the regulatory authorities in India have changed their approval process. So what the representative was telling me is that now they don't take up the results of the CE approval and just copy them in India. You have to do an Indian study and you have to show the results in India. Only then will you get the approval.
But we don't have long-term follow-ups in India.
So we have like few of my patients I started doing around 2 years back.
Okay.
So I have like 7 or 8 patients are now more than 2 years. They're not following up. That's why I don't have their IOP. They have not come back to get it done. But otherwise, a lot of surgeons who actually started initially,
Yeah.
in fact, Dr. Sunita Dubey in Shroff is also doing for the past 2 years. She also
2 years.
have quite a
Well,
long-term data.
actually, even before that, she has been doing.
Right.
Yeah.
And is there any duration, like the effect wears off after a certain duration? No, nothing, right?
That's the best part, that the
Yes,
effect maintains.
it
Like
maintains.
you will not see it going downhill. It will get better. In fact, sometimes it happens
They
that
open up the
initially,
channels.
yes, so initially first month you achieve your target, but you just achieve the target, but 6 months later you see that it's come further down.
Any other incidents of tube blockage or any other complication that you have noticed in your cases?
So in my cases, I haven't had a complication of blockage of the stent, but an earlier the earlier version, which was the inject. This is inject W, right? So W is for the wide uh,
Wider
shoulder.
flange.
Yeah.
Yeah.
So the iStent inject actually had a tendency of over implantation. That is that when you push it, it would go through, and even the shoulder region would actually get implanted into the trabecular meshwork. So there, sometimes it would be difficult to retrieve it. I saw a presentation where they showed that you can laser it actually. So you put a lens and gonio lens, and you laser the opening of that area of the trabecular meshwork, so it kind of bursts, and then you can see the stent and it starts functioning. But I have implanted only 3 or 4 injects. Rest of them, all of them are W. and
And
never had a
all
problem.
these patients were POAG patients and one was PACG, or have you widened your
I
indication?
I have done steroid induced pseudo exfoliation and POAG.
POAG.
A few of your patients had CDR 0.3. So
Right.
were they like ocular hypertension, or how were
So
they?
that lady with point 0.3 was that one which I was discussing.
PACS. Acha. Okay, okay.
Primary angle closure suspect who underwent a PI 20 years back, and she was on 5 drugs actually. Matlab combination of,
So
she was on three
basically
drugs.
PSC then, not PSCS.
So yeah, primary angle closure. That's why the thing is that in these kind of patients, see why it worked in my practice is because there are a lot of patients who are complying well, who have less cupping and were diagnosed glaucoma early on. Like there was a person who basically in this practice, because Dr. Roop, my father, was seeing a lot of glaucoma from early on. So he has seen many patients who have been on drugs, been compliant, and not had a progression of glaucoma. So they are very good candidates to be undergoing this procedure because now they are maintaining the same state but drug free. And I am confident that the stent will work because the medications have worked for them for the past 8 years. So if a patient like just recently, I had a patient who came from somewhere far for this procedure, and he had a point 0.8 or 0.7 cupping and an IOP of I think baseline IOP was 34 or something. But with 4 drugs and various combinations tried, he could only come down to 26. And open angles, there was no sine K. I could clearly do a stent, but it would not work. Because if at 34 IOP and with 4 or 5 drugs, you've just come to 26, and there is no way that I am able to control you on medications, then it is highly unlikely that the stent is going to make him drug free. So that's why I suggested a trap.
Okay. Any more questions?
Yes, it was a really excellent presentation, Dr. Prakhyat. Uh, I I called these company guys, I think, in the later half of 2022, and I tried a few eye stents, but because I myself was not convinced with the equipment and cost involved, so probably it didn't take off in Varanasi. But I feel that I should be starting now with especially the W version. That time, I think W was not available. It was the second generation which was available in India. So looks fine to me. I mean, my all questions were answered by you and my colleagues asked those questions. So it was a nice presentation. I think we should be starting and seeing for ourselves how it goes. Obviously, the cost remains a biggest uh, roadblock, and earlier in 2022, 23, I think most of the insurances were also not covering it. So I could not actually start in Varanasi.
Right.
And yes,
Actually, sir, in fact, insurance has just the reason that it's picking up in India is because insurance is paying for it and there
yeah,
is no capping. So because the cost of the consumable has to be paid. So 1.56 तो आना ही है. तो
yes,
बाकी जो कटेगा वो कटेगा थोड़ा बहुत. तो that is why it makes sense. Otherwise,
yeah.
pay like out of pocket patients, I have just done like 5 or 6,
Mm.
and that too like
Difficult to convince patient if you are not yourself convinced. I mean, it works like that with me,
honestly, sir,
with most of us.
that is the way that it has to be. That is why I would say that first we should go for like those patients who have insurance, because worst come to worst, what will happen? That it will not
Yeah.
work and we'll have to do a trap later. Okay.
Mm. Yes, that can be done. Okay, thank you so much. Thank you so much. I'm at the dentist clinic for my son's dental something. So I'll just sign off. Thank you very much.
Thank you, sir.
Beneath had some questions. I think Beneath you can ask also. So actually, he asked about how to counsel such cases. Chat में था.
अच्छा.
Call.
Counseling is basically, I feel, first we need to counsel ourselves what we want from this procedure and what kind of patients we have. And if we have a good number of glaucoma patients in our follow-up, and definitely they'll have various kind of profiles. So we have to ourselves manage all these things and understand how and when to proceed for such a procedure. And the selection of the patient is required from us.
So I think first of all, gonioscopy regularly
Yeah,
is something that has to be there. So in fact, like sometimes now what happens is that patients come for they have had follow-up for a long time, and they come with their file. They are regularly showing every year, but I can't find a gonioscopy finding. So I do their gonioscopy again because I am looking for patients who can undergo this procedure and be drug-free. So I think Dr. Darshna is very well versed with all these things, so she can start her patients and ask her fellows also to be doing gonioscopy regularly, so that
Yes.
we pick up open angles. So when we pick up open angles with glaucoma, then we know there is a potential candidate here.
Yes. I would
so what?
actually start
Yeah,
doing. But वही cost factor is the biggest thing. Let's see.
You can actually, most of the patients have insurance, and I have done patients who have capping of 5 lakh. So both their eyes got paid within
yeah,
those 5 lakh, because consumable is not something that can be denied by the insurance company.
yeah.
So that works out in your favor. That is the only thing. In fact, for me also it was difficult to convince patients earlier, because I myself was not very confident कि भाई कैसा करेगा. और देखो, दूसरे का कहना और अपने हाथ में होने में बहुत फर्क होता है. जब अपनी आंख के सामने होता है तो भरोसा होता है कि हाँ भाई काम कर रहा है. नहीं तो आप ये सोचते हैं कुछ ना कुछ मेरे हाथ में गड़बड़ हो सकता है. जो
In how many cases do you actually get a hang of it कि how मतलब how to do it?
you will be able to do it in the first case itself. You basically, the visualization is the main thing.
Visualization तो is
In
मतलब
fact,
I have seen visualization तो I have done before also, but I have not used this iStent.
in fact, early starting में तो I used to do that. I got the prisms first. So I didn't have a patient, but I got the prisms from them. So I started visualizing first, just aligning your microscope, marking it, so that during the surgery you don't have a hassle. When you turn it, then you see that the XY also doesn't function the same way that it does in the coaxial
Normal.
orientation. So all those things, if you do that early on, then for the surgical part it's pretty easy. You just start practicing with the cannula, just place the prism, not indent it enough, not get folds on the cornea. You know how much to fill, you know how to approach. If you have done that part, then injecting itself is not a hassle at all, and you get
Sometimes,
Oh,
multiple clicks, so it's not.
Prakhyat, sometimes like you have done a pre-operative gonioscopy, but like intraoperatively, the angle structure might, change. Probably it might deepen. And did you have any difficulties locating the trabecular meshwork if you don't see the reflux?
So that's what happened, ma'am. That's what the one case I showed with less pigmentation did not have a reflux also. So no reflux. Iris processes are that's the first time I saw like so many broad-based kind of iris process with very deep AC, no pigmentation. So actually, and that day the technician was in the OT. So he was asking me to implant at the point which was actually the ciliary body band. And he was saying that where I am implanting is the Schwalbe's line. Because I had done a pre-operative gonioscopy, I knew that the angle is too deep, and the first pigmented thing that I am seeing is the trabecular meshwork. There is no Schwalbe's line there. So because I was aware, so basically you orient yourself that way कि आगे से पीछे देखूंगा तो सबसे पहली पिगमेंटेड चीज जो दिख रही है वो क्या है, या पीछे से आगे देखूंगा तो कौन सी वाली पिगमेंटेड चीज इज द ट्राबेकुलर
Does
मेशवर्क.
it
सो
help to you now counting from the iris upwards? Like,
It
or
helps, but
it helps.
you have to do that counting on the slit lamp first
Yes.
after making the wedge,
Hmm.
so that there you know that which pigmented line is actually the right line. And also there are many ways to manipulate it. So you can reduce the pressure, like you can underfill, and then you
Then
press on the nasal part, so there will be some reflux of blood.
plus blood motions.
Sometimes what I did once is that I went in, poked and came out just to see the ooze of blood, because I was confused if that is the trabecular meshwork or not. And when I saw that blood trickled from it, then I went just adjacent to it and injected quickly. So you can do a lot of things. It's not like it's, if you look at the procedure, it's just a 2-minute procedure. But initially you will take time in this visualization and getting it right. And once you start getting it right, then all of your sitting position and all those things, they start falling in place, and then it becomes quicker and quicker. So now it is, some days it's like just 1 minute. Although I keep like 30 minutes time extra for an iStent in my OT schedule, but sometimes it just happens that it ends in just 2 minutes. And sometimes I have to like take it out, rethread it, and inject it. And earlier it used to be frustrating and also not good for my heart, because once you've done 2 times and then you have only 2 clicks remaining, and then you're thinking कि भाई अब क्या होगा. So but they help, like the company people, they have spares, like I have spares right now. So if I come to like one of you, I would bring my spares, because now I have a lot of stents where clicks are remaining. So I have like 10 like 20 clicks with me, empty clicks, so I'll bring them with me, so that if you are injecting and we have like 4 chances which we miss, we still have like 5 more.
Okay.
बेसिकली जो इंजेक्टर है उसमें दो 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 स्टेंट्स हैं डाल सकते हो, लेकिन और एक्स्ट्रा दो
Click
इंजेक्ट कर
सकते
सकते हो,
दो
दो
चांसेस
कर
और है,
सकते
हाँ.
हो.
हाँ.
उसके बाद इट विल नॉट क्लिक.
उसके बाद वो उसका बंद हो जाता है वो क्लिक होना.
Acha, do you need any viscoelastic with this prism to keep on your? What do
राइट.
you use?
हीलॉन.
Normal. नहीं, prism and cornea के बीच में. Also
हीलॉन.
Hela.
बिकॉज इफ यू पुट HPMC, वो जल्दी से वो फ्लो कर जाता है. एंड इफ यू like don't put Helon, then it kind of becomes, when you put Helon and place it na, then it stays there. If you put Helon GV, then it is kind of like a mount there, तो वो थोड़ा ऐसे गिरता है prism. Helon की consistency best है.
इसमें प्रख्यात फीलिंग क्या आ रही थी? पंक्टम प्लग वाली जैसी फीलिंग आ रही थी, देखने में वैसा लग रहा था जैसे लोडेड आते हैं,
एक्चुअली
इंजेक्ट करते हैं.
हाँ, थोड़ा बहुत आप कह सकते हैं माइक्रोस्कोपिक फील वैसा ही है उसका.
बस.
जब आप ट्रोकार से जाते हैं ना और वहां पे वो स्टॉप होता है, तो यू गेट अ, मतलब प्रॉपर होल्ड आता है उसमें. मतलब इतना कोई वो ऐसी सटल चीज नहीं है, मतलब
ओके.
आराम से कर सकता है कोई भी. कोई ऐसा बड़ा काम नहीं है. जो प्रत्युष सर बोल रहे थे पुराने वाला, उसको ऐसे करके थ्रेड करना पड़ता था, उसको कोई इंजेक्टर नहीं आता था. तो
ओके.
उसमें इट वाज मोर लाइक इट रिक्वायर्ड अ लॉट ऑफ हैंड आई कोऑर्डिनेशन.
यस.
इसमें तो इट इज फेयरली सिंपलर. सो आई थिंक डालना सर प्रॉब्लम नहीं है. जो
बेसिकली
कैटरेक्ट कर
मेनली
सकता है
जो
वो
है,
आराम.
आपको गोनियोस को भी करना पड़ेगा अच्छे करके, ओपन एंगल पकड़ना पड़ेगा, या पिगमेंटरी ग्लोकोमा मतलब मायोपिया ऐसे टाइप का डीप एसी जिसमें अच्छा करके ट्राबेकुलर मेसोर आइडेंटिफाई कर पाओगे, उसमें करना है. और जो पेशेंट्स हु एक्चुअली रिस्पॉन्डेड वेल टू ड्रॉप्स बिफोर, लाइक नॉट, या बहुत एडवांस ग्लोकोमा नहीं, माइल्ड टू मॉडरेट ग्लोकोमा, जो जस्ट दे वांट टू रिड्यूस देयर ड्रॉप्स, ऐसे केसेस को मतलब बहुत ही कंजर्वेटिव वे में पेशेंट को चूज करके कर सकते हैं.
स्टार्ट करने में तो सर ऐसा ही करना चाहिए. मतलब क्योंकि स्टार्टिंग में अगर रिजल्ट नहीं आएगा, फिर आपको लगेगा कि भाई काम नहीं कर रहा. तो पहले में तो यही है. मैंने तो पहले जो पेशेंट सुने थे उसमें कॉम्बिनेशन ड्रग्स, मैक्सिमम 2 ड्रग्स, मतलब टोटल 4 ड्रग कॉम्बिनेशन पे पेशेंट जो था उसको चूज चूज करेंगे. और जो पेशेंट कंप्लेन कर रहा है ना कि मेरे को लाली होती है, चुभन होती है, ड्राइनेस होती है, उसको देखेंगे. जो कंप्लेन ही नहीं कर रहा,
राइट.
खुश है, तो ठीक है, चल रहा है.
बिल्कुल ठीक बात.
ठीक है. एक्चुअली
ओपन एंगल तो आइडेंटिफाई करने ही है, और जिनके खूब ड्रग्स चल रही हैं काफी समय से कंटिन्यूसली, वो हैं. एंड डेफिनेटली एज पर द पेशेंट्स नीड भी आपको provide them options, and definitely the patient selection lies on us only.
Okay. Any more questions? Okay, I'd like to extend my heartfelt thank you to all of you for your active participation and presence today. Your insightful questions, engagement truly made this session a rewarding experience. I would like to thank Dr. Prakhyat Roop for truly exceptional and enlightening presentation. Your expertise and clear explanation of such a complex yet making it so simple topic has been invaluable. Your talk has also inspired us to do more of, to start doing these procedures in our practices as well. I would also like to extend my gratitude to our panelists, Dr. Neha and Dr. Pratyush, to give their valuable time and insights. And thank you, organizers, also. All right.
Thank you.
Thank
Thank
you.
you.
Thank you.
Good
Good
day.
day.
Thank you.
Thank you to all the seniors. See you.
Thanks, Dr. Prakhyat, and thanks everyone in participating for such a good interaction.
Thank you.
Thank you, sir.
Thank you.